Good morning. May peace be upon you. This is me, Professor Shukr again. And today we are going to talk in this video session is about carcinoma stomach. And we are going to talk about carcinoma stomach not per se, but we are going to discuss a stepwise approach how to deal or how to manage a patient of carcinoma stomach. Once the patient comes and you have taken the history and done clinical examination, so the data you obtained from history and clinical examination, by the time it finishes, you should have a fairly good thought, okay, is this a carcinoma stomach or not? And then as it is carcinoma stomach, does carcinoma involve the proximal or distal stomach? Or is it early, advanced or metastatic disease? Because carcinoma stomach is divided management-wise into an early disease, advanced disease and metastatic disease. Then the second step would be to confirm the diagnosis by means of endoscopy and biopsy that it is a case of carcinoma stomach. And once you have confirmed, then comes the step 3. Once you investigate the extent of spread, and this is important, okay, how much spread it is within the abdomen or outside into other systems, so that we know it is early, advanced or metastatic, because that is going to determine whether the cancer is curable or it's not curable, and its treatment primarily is surgery or it is chemotherapy. Then patient status to determine whether the patient is fit to undergo surgery or not. After this thing, then the step would be give neoadjuvant chemotherapy to a case of carcinoma stomach, irrespective it is advanced or not, or the primary treatment is surgery or not. Then obviously before operation, for those patients whom surgery could be done, which includes the early cases and advanced cases, preoperative preparation, then operate. That could be a type of a gastrectomy, and then again chemotherapy. So therefore, a step-based approach will be to determine, have a thought, does carcinoma involve the proximal distal stomach? Is it early, advanced or metastatic? Then confirm the diagnosis by investigation of endoscopy and biopsy. Then confirm the extent of spread of determine it is curable disease or not or metastatic, again by means of investigation, and to determine patient status, again by means of investigation, whether the patient is fit to undergo surgery or not. Then give neoadjuvant chemotherapy, prepare the patient for operation, operate, followed by chemotherapy. Now coming to step 1, when you are going to suspect a patient could be having carcinoma. Now generally speaking, any patient who has a recurrent or persistent dyspepsia, which is not responding to the usual treatment, or maybe responding to the usual treatment of antacids, etc., and treatment of H. pylori, but is reoccurring again and again, one must suspect the patient could be having a carcinoma stomach. Any patient who presents with an unexplained anemia, you have exhausted the investigations and you cannot determine what is the cause of anemia, one must think of carcinoma stomach. As in such cases, one also thinks of carcinoma colon. Any patient who presents with a history of dysphagia which points toward an obstruction at the lower end of the esophagus, which is in fact joining the upper end of stomach, which is called as the junction, one must suspect carcinoma stomach. Any patient presenting with the symptoms of gastric outlet obstruction, one must suspect the patient may be having carcinoma stomach. Especially if any of these, in addition to this, there are general features of carcinoma, which are significant history of weight loss, significant history of weakness and general symptoms. Now you see this chart. In early, there is usually history of dyspepsia or unexplained anemia, and on examination you don't find anything except possibly pallor. So in early carcinoma breast, there are minimal symptoms and usually there is no finding except possibly pallor. If now a patient is giving a history of dyspepsia, early satiety, bloating, distension and vomiting, in fact these symptoms also fit into dyspepsia like bloating and satiety which is related to GIT. Gastric outlet obstruction, patient is complaining of a vomiting which is projectile, which has residual food particles which are not supposed to be there. If it doesn't show bile, it means patient is giving a history of gastric outlet obstruction. Or dysphagia, then patient is suffering from advanced carcinoma stomach. Unless and until there are associated metastatic features present, then we are going to call it a metastatic disease. Now if you examine a patient with advanced carcinoma stomach, on general physical examination, there is going to be pallor. Then these patients give history of significant weight loss and weakness, so therefore signs of significant weight loss will be present. That could be very simple. That could be decreased BMI because you can weigh the patient, you can see the height. You can see the temporal fossa to assess the mass of the proteins, interosseous fossa in between. You can see the bulk of muscles. You can pinch the fat and can assess what are the fat reserves, what is the protein reserve in the patient. And during investigation, serum albumin level, they can all point towards advanced. On abdominal examination, if the patient has distal cancer and the gastric outlet also obstruction, then when you're going to examine the patient and you examine the patient from the side and then a foot end, you're going to see a scaphoid abdomen because patient is wasted usually. But you might see a bulge, and that bulge would be present where is the normal site of stomach over here, which is the upper abdomen. But when you're going to do a Carnot sign, the bulge is going to disappear. That bulge is because of the distended stomach. And since it has a residual food particles, when you're going to shake the patient, you might hear succussion splash. Not only this, if he's wasted and a tiny abdominal wall is thin, you may be able to see the peristalsis waves or peristaltic waves in the stomach. In addition to that, see if the tumor is present distally, it's advanced, then it has a mass. So you might be able to feel a fixed hard mass in the region of pylorus and antrum, which may be mobile, and if it's advanced and inventing into adjacent structures, it may be less mobile or fixed. It is a hard mass. So therefore on inspection, a scaphoid abdomen with a visible bulge in the epigastrium that may be showing peristalsis and disappears on Carnot, distended stomach due to gastric outlet obstruction. On palpation, hard fixed mass palpable. If pylorus and antrum are involved, it's olive shaped in the pylorus region and succussion splash could be present. These things show it's an advanced carcinoma stomach. In addition to this, and very rarely, in absence of many of these, I'm saying very rarely, if there's a history of associated symptoms, of involvement of any other symptom, then one should think it's a metastatic disease. For example, if it is involving lungs and pleura, patient may complain of dyspnea, breathlessness. On percussion, you might find dullness and so on and so forth. If it's involving bone skeletal system, patient may complain of persistent severe pain at a site of bone. Then headache, early vomiting, increase the ICP, showing the patient may have mets in the brain. Not only this thing, if you do examination, general physical examination, Wilkes node means patient has a metastatic disease. Mind you, Wilkes node is present between internal jugular vein medially, subclavian vein and clavicle. So therefore, if you have to feel, then in a relaxed neck, you have to dig your finger deep behind the lateral side of clavicle to feel it because of its boundaries. Left axillary lymph node, thrombophlebitis, especially migratory thrombophlebitis, deep vein thrombosis, they suggest a metastatic disease because in metastasis, these are coagulopathic state might occur. In abdominal examination, a large novi liver mass indicates metastasis into liver. Shifting dullness may be a site the tumor has spread into the peritoneum and resulting into malignant ascites. And if the fluid is more fluid-thin, mind you, in distended stomach, you don't get fluid-thin, usually it is succussion splash. And in females, you might find during perirectal pelvic examination, the ovaries are hard and they're enlarged. It means met onto the ovaries, Krukenberg, or in the pelvis because of the deposit of the tumor. Normally, no shelf is felt, but in digital rectal examination, you might feel a shelf. These always indicate it's a metastatic disease. By these symptoms, you can also tell in examination whether the cancer is involving distal stomach or proximal stomach. Dysphagia is a symptom of proximal stomach. Gastric outer obstruction, hard fixed mark in the region of pylorus antrum, they all point towards a tumor which is involving distal stomach. Now, simply on the basis of history and clinical examination and endoscopy with biopsy, we have reached to these conclusions. Now comes the point is to confirm it by means of investigation. What is our thought? Which we have reached to the conclusion after history and clinical examination. The first investigation possibly is endoscopy with biopsy. So any patient with a suspected case of carcinoma stomach or any symptoms related to stomach, the investigation of choice is upper GIT endoscopy. Now mind you, if there is a gastric outlet obstruction and the stomach is distended, it is always good to empty the stomach first by putting a nasogastric tube and cleaning out all things before subjecting the patient to endoscopy. In early carcinoma stomach, even endoscopy can give you pointers whether it is an early or it's a advanced, locally advanced cancer. Because in early carcinoma stomach, the tumor is either the mucosal surface is slightly elevated or it is going to press down because it is early. So therefore, in endoscopy, you may find it to be protruding above the surface, superficial to surface, or excavating to surface. These three terms refer to the plane of the margin of the mucosa, protruding, superficial, excavating as per Japanese classification. If you advanced carcinoma stomach, you may actually see it like a polypoid growth, or it could be an ulcer with margins which are everted, or it could be a stenotic lesion, or it could be a flat lesion in which mucosal velocities are lost, or you may get an irregular surface. Now it is very, very important. Okay, once endoscopy is done, please don't take one biopsy specimen. 8 to 10 biopsies of the lesion are recommended so that the whole lesion is well presented. If it's an ulcer or a growth, you can divide into quadrants, into 8 quadrants, and from each quadrant take a biopsy. And you have to take biopsy from the adjacent mucosa also, Because we know this thing, in early cancer, the mucosa, it does not extensive growth over the mucosa. So therefore, chief of digestive mucosa, and you have to take biopsy also for H. pylori. Because H. pylori is a cause of cancer, is a predisposing cause, etiology factor is cancer in distal stomach. Now, if you see do endoscopy, this is normal. This is normal mucosal rugosities. Now, this is going into further. Now, if you compare this with this, as you see, there is loss of mucosal rugosities, and there is a growth. This is a polypoid growth. It is projecting up. This one. So this is how on endoscopy a cancer might look. Now, after doing this thing, now we have a set of investigation which is going to confirm whether it is early, it is advanced, or it's metastatic. And these set of investigations which are going to tell us fitness of the patient, commenting upon how well his systems are working. In spread of cancer, CT scan abdomen with contrast is done. For the metastasis in the abdomen in all cases. In all cases, CT scan of the abdomen with contrast should be done. Then, specialized investigation may be required if we are suspecting metastasis somewhere. For example, CT scan chest for if you are suspecting metastasis in lungs or pleura, CT scan bone if bone is being involved, and if clinical signs of metastasis are present, then all of these are done. Laparoscopy, if available, definitely has a role in staging also. Especially if there is a confusion, okay, whether it's a locally advanced, but are there metastasis in that? Or even to determine its resectability, it gives you a better idea than CT scan, a laparoscopy of the abdomen, a diagnostic laparoscopy of the abdomen. Ultrasound also has value. If the date of CT scan and these investigations are there, we can't do that, then possibly we can proceed it by ultrasound of the abdomen. In early cancer of the stomach, ultrasound, endoscopic ultrasound definitely have a role if facility is available, because the advantage is it can tell you more clearly, it can see the wall of the stomach, the different layers of the wall of the stomach are visible on endoscopic ultrasound, so therefore it can help in T staging. Then for fitness of the patient, obviously we have a blood hemoglobin, we require that because patient is usually anemic. ECG, X-ray chest, blood glucose, creatinine electrolytes, LFTs, then hepatitis B and C and COVID serology. But in addition to this, you might have to add other specialized investigation if patient has already a comorbid and disease is not under that much control. For example, patient with a history of MI, patient with a history of other diseases. In addition to this, you may go for echocardiography, you may go for CT angio. In case lung problems, then you may have to undergo for lung function test, but these are rare, but they could be called for. If you see this is a CT scan, this is stomach, this is contrast in it, And as you can see clearly, this is wall, and here you can see the wall thickness. So this is a cancer. Okay, we are going to take a break over here, and then I'm going to start part 2, and we're going to proceed further. Have a good day. Take a cup of coffee or a tea, and then join me again. Thank you very much. Assalamu alaikum.